everyone. I am here to present the intraoperative TE assessment, transesophageal echo assessment for HOCM. Previous lecture series had HOCM in detail description about the etiology, pathophysiology, symptomatology and all. So in this lecture we would just highlight why TE is so important for HOCM patients undergoing surgical myomectomy. So, as it is known, intraoperative TE is a standard of care for assessing patients with HCM undergoing surgical septal myomectomy. Why? Because at various phases during surgical septal myomectomy, the changing hemodynamic conditions may lead to worsening or improvement in LV outflow tract obstruction by change in preload or afterload SAM of the mitral valve or sympathetic stimulation. All this help in allowing proper surgical planning, intraoperative hemodynamic monitoring, assess post-procedural adequacy of the repair and detection of immediate complications. So, a few slides just describing the pathophysiology and types of HOCM. So, HOCM is basically non-obstructive, obstructive or latent obstructive. Non-obstructive where the LVOT resting gradient is less than 30 mm of Hg. Obstructive where the LVOT resting gradient is more than 30 mm mercury, and latent obstruction where the LVOT gradient at rest is less than 30 mm Hg, but on exertion or provocation the gradient increases to more than 30 mm Hg. So basically the patient with obstructive or latent obstructive come for surgical management. So these are the various LV cavity types in HCM. The first one, the most common one, are sigmoidal or reverse curve pattern. The sigmoidal pattern, as you can see in the first pic, there is a septal protuberance at the basal level leading to a concave septum, whereas in reverse curve it is in the mid level leading to a convex septum, whereas the apical there is a apical hypertrophy leading to the pattern of ace of spades, which is around 10%, and the neutral HCM where there is a straight septum and uniform dilatation. So these are the various types of LV cavity found in HCM. So coming to the proper physiology, the proper physiology is due to the hydrodynamic force on the mitral leaflet causing SAM. So the basic SAM is because of the thickened interventricular septum. It might be because of the sometimes because of the increased anterior length of the anterior mitral leaflet, and sometimes the abnormalities in the subvalvular apparatus. So the hydrodynamic force during the early systole, as you can see, the jet is most directed post because of all this disturbances. There is a posterior and lateral directed jet, so causing a flow drag which is dominant during the early systole, and this leads to the anterior mitral leaflet tries to because of this there is a contact between the anterior mitral leaflet and that of the septum, causing a pressure difference in the outflow, leading to the hydrodynamic force in the later part. So ultimately all this result in SAM leading to the LVOT gradient. So it is like this, the SAM severity is directly correlated with the higher LVOT gradients. So all this can lead to following pathophysiology. One is dynamic LVOTO, mitral regurgitation, diastolic dysfunction, LA can be dilated, and arrhythmias, and because of the thickened septum ultimately there can be myocardial ischemia. So all this cause problems in HCM patients. So our core lecture starts from now. So what we have to check for is in TE is the anatomy of it is divided into three parts. One is the anatomy of LVOT, then is the assessment of mitral regurgitation, and then is the dynamic LVOTO obstruction. So anatomy of LVOT, where we assess the length of anterior mitral leaflet, the septum thickness and the papillary muscle abnormalities. Assessment of mitral regurgitation. Yes, mitral regurgitation almost 80% is due to SAM in HCM patients, and in 10 to 20% there can be some intrinsic mitral valve abnormalities also, that also we should take a note of. And then dynamic LVOT obstruction. Dynamic LVOT obstruction is the obstruction which is seen in systole. So we have to, we can see a mosaic pattern in the LVOT. We have to measure the peak velocity and gradients, and at the same time we have to rule out the fixed LVOT obstruction such as subaortic membrane or fibrous ridge or severe AS. So all this we have to rule out at the same time. Coming to the first septal anatomy of LVOT, that is septal assessment and anterior mitral leaflet length. So as here we can see TE of mid-esophageal long axis view, where you can see a thickened septum. These are best assessed during the diastole when the heart is relaxed, because it is during that time where the surgery is done on CPB. So the following 4 measurements can be looked into, which are color coded here. So first is the orange line which you can see in the zoom picture is the distance from the RCC to the maximum septal thickness, and then the next is the maximum septal thickness we have to measure, and then from distance from RCC to the distal narrowing we have to measure, and the amount of distal narrowing that also we have to see. So ideally they say if the septal thickness is more than 15 mm or septal to free wall ratio is more than 1.3, it indicates the thickened septum. And anterior mitral length, the two in diastole from the annulus to the tip of the anterior mitral when the valve is completely open, we have to measure. So if it is more than 30 mm or 16 mm per meter square is significant. So why do we need to do this? So we have so that we can get the proper proximal extent and the distal extent of myomectomy resection. For example, the distal myomectomy resection point should be extended beyond the contact point between the AML and the interventricular septum. So by all these measurements we can give a surgeon a better idea till where the resection has to be carried out. So coming to the subvalvular, that is papillary muscle abnormalities. As we can see, the papillary thickness in transgastric view, where the papillary muscle thickness, if it is more than 1.1 centimeter, it is significant. And here on the extreme right we have various papillary muscle abnormality pictures. So all these papillary muscles are better assessed during the mid-systole level, mid-systole timing. So what are the various abnormalities? We can see that the anterior displacement of with respect to the interventricular septum, and then sometimes we can have a multi-headed bifurcated or an accessory papillary or muscle. Sometimes there is a direct insertion without chordae, and then the abnormal papillary muscle having an abnormal attachment to the septum and the anterior lateral wall. So all this can cause some amount of obstruction either at the mid cavity level, and ultimately it can lead to SAM. So this is important. Next, coming to the assessment of MR, as we discussed, SAM is the main culprit for mechanism for MR. Otherwise, there are intrinsic valvular abnormalities seen in 10 to 20% patient. So as we see in figure A and B, that is mid-esophageal 4-chamber view, because of the SAM, there is an anterior displacement of the coaptation point and leading to the interleaflet cleft, ultimately leading it to MR. So the characteristic jet seen in SAM is posteriorly directed jet, because the anterior leaflet and the coaptation point has been shifted anteriorly. So the characteristic posterior jet in mid to late systole is the characteristic feature. And if you see M mode, we can look at two features. One is the distance of the mitral leaflet to the septum and the duration of the mitral to septal contact. So for example, if the distance is more than 10 mm and without any encroachment, then it is mild. If the distance is less than 10 mm with a brief contact, then it can be graded moderate. And severe if the distance is less than 10 mm and the contact if it is for more than 30% of the systole. So this gives a better assessment of MR. And then coming to dynamic LVOTO. Dynamic LVOTO is also because of SAM. SAM is the most common cause, up to 80%, but in 20% can be independent of SAM. That is because of the mitral valve abnormalities or and sometimes the subvalvular apparatus abnormalities. So those has to be properly identified. So if you see in figure A, that is midesophageal long axis view, where you can see a turbulent flow in the systole in the LVOT zone. So that is important. And then if you put the color Doppler in the transgastric long axis view, then you can see the pressure gradient. The pressure gradient will be more than continuous in the continuous wave Doppler. If the pressure gradient is more than 30 mm Hg at rest or after provocation, it is significant. So the characteristic envelope of this is a dagger shaped envelope with a mid or late systolic peaking. This is very important. The dagger shaped envelope with mid or late systolic peaking. And finally in M mode, if you see in M mode, there is a fluttering and mid systolic closure of the aortic valve is seen in this setting of dynamic LVOTO. So as we told, because of the intraoperative like general anesthesia and positive pressure ventilation and various volume shifts in the intraoperative period, sometimes the dynamic LVOTO will be hidden. So we need to go through provocative measures so as to properly evaluate the LVOTO. So isoproterenol can be used at 12 mics, bolus can be used, dobutamine can be used. Sometimes even tapping when the pericardium is open, tapping with forceps create a premature ventricular contraction which accentuates the LVOT gradient, and this is known as Brockenbrough-Braunwald marrow sign. So as we told, the dynamic LVOTO has to be differentiated from the tracing of AS, and that is AS or a fixed LVOTO, or sometimes this traces has to be differentiated from MR as well. As we know, the MR trace, if you see the picture in the right, the MR trace in non-HOCM, MR trace velocity is definitely high, and the duration or the extent of this is also varies according to the cardiac cycle. So based on that, we can definitely differentiate MR from the LVOT or AS. But whereas in HOCM MR, you can see the mid to late systolic peaking. So that is what is characteristic. And now if you differentiate the dynamic LVOTO to that of AS, if you see a normal AS, you can see a smooth early systolic parabolic pattern, but whereas in dynamic LVOTO we see the peak in the mid or the late systole, that is a dagger shaped pattern is seen in the continuous wave Doppler. So it is very important to distinguish the different types of continuous wave Doppler patterns in them and find out the differentials. So, and as we know that in patients with HCM, there will be some amount of diastolic dysfunction. All the parameters of diastolic dysfunction should be properly assessed, like restrictive filling pattern, increased E by A ratio in the mitral inflow patterns, and then LA enlargement is observed, and PA pressures can increase, and in pulmonary vein also dominant D waves and all are observed. So all this has to be properly assessed. So coming to a single slide on the anesthetic management, the do's and don'ts. So anesthetic management, basically we have to avoid tachycardia, hypercontractile state, hypovolemia and hypotension. So all those drugs which causes these things should be avoided. So fasting or dehydration is not acceptable, like prolonged fasting or dehydration should be avoided. And then pulmonary artery catheter is usually avoided because it can cause arrhythmias, and because of the a compliance change in the LV, it can overestimate the pulmonary capillary wedge pressures also. And then high tidal volume and high PEEP should be avoided because they decrease the preload. Then atropine and glyco as a pre-medication can be avoided. And we have to be little careful with arrhythmias because it can cause hypotension and digoxin because there is a positive inotropic action. So that has to be considered. And anytime rapid IV induction with propofol and all should be avoided because it can cause hypotension and myocardial depression. And then ketamine, yes, it can cause tachycardia and exacerbate pulmonary hypertension. So we have to try to avoid. But all in a graded fashion with aliquots can be used properly. And then histamine releasing muscle relaxants like atracurium and mivacurium should be avoided. Nitrous oxide, yes, definitely should be avoided because it can increase the pulmonary hypertension. And beta adrenergic agents are usually not suggested in this, like dopamine, dobutamine, adrenaline should be avoided. Vasodilators and phosphodiesterase inhibitors also should be avoided in these patients. So what we can use, yes, TE guided fluid management is much better in such patients. Maintaining sinus rhythm with beta blockers, calcium channel blockers is better. Dexmedetomidine can be used. Then as we told, the titrated induction agents, slow and titrated induction agents will avoid this unnecessary hypotension and all. Muscle relaxants without histamine release like vecuronium or rocuronium can be used. Sevoflurane is a better inhalation agent because of its minimal effect on heart rate and SVR. Pure alpha agonists like phenylephrine can be used, and vasopressin is also helpful in maintaining pressures in such patients. So what is the surgery? Usually they undergo septal resection of the hypertrophied septum. Apart from that, sometimes plication of the anterior leaflet, mitral leaflet, and the release of the abnormal papillary muscle attachments. So these are the three main steps which are usually involved in patients undergoing HOCM repair. So the complications in the decreasing order would be atrial arrhythmias, heart block, ventricular arrhythmias, LV rupture and iatrogenic VST. So these could be the complications. So now in the post-op, post-surgical evaluation is very important in such patients. So we have to have we have to have a laminar LVOT outflow. As you see, the initial picture showed the jet directed posteriorly and there is a turbulent flow. Once the resection is done and the papillary muscle have been repaired properly, we can see the proper laminar anterior flow in such patients, and any residual SAM should be ruled out. So for example, if we are doing a mitral valve repair in such patients, and apart from that, conditions like hypovolemia, hypercontractile state, and all these things have to be considered before evaluating SAM in such patients. So what are the risk factors for residual SAM? The posterior leaflet more than 15 mm, the anterior to posterior leaflet ratio of mitral to less than 1.3, the C-sept distance less than 25 to the coaptation point to that of the septum is less than 25 mm, and iotomitral angle less than 120 degrees C, and LV internal diameter less than 45 mm. So all these are risk factors for residual SAM which has to be evaluated properly. And the other aspects would be sometimes there would be an iatrogenic injury to the aortic valve. So you can see the picture in the top showing in the mid-esophageal long axis view, where you can see a small cleft in either NCC or LCC, which can be confirmed with a short axis view. So those has to be noted and has to be addressed immediately. And iatrogenic VSD is one of the complication, so which has to be addressed in the post-operative immediate post-operative period. So you can see a high velocity in the mid-esophageal aortic long axis view. You can see a high velocity flow from LV into the RV states that. So it has to be differentiated from septal perforators, where the septal perforators are usually a low velocity diastolic flow into the LV cavity. So it has to be distinguished from the iatrogenic VSD. So apart from that, the other part of post-surgical evaluation is LVOT peak gradient, septal thickness after resection has to be noted, and then LV function, RWMA, and any papillary muscle injury or has to be addressed. So this completes the TE assessment of the HOCM patients undergoing surgical myomectomy. So these are my references. The basic references are I have like took a lecture from Dr. Marcus Salvatore for TE of septal myomectomy, and a very good paper on pre-intervention imaging and management of HOCM by Jacob M.G. et al. And the images I have collected from the following references. Thank you.